You've done some work on the ankle injuries, and we covered the information last week, and I'll have that video up for you soon. The next one, Angela Jones, 32-year-old real estate agent, a weekend netball player, and they have presented with a referral from the GP, non-specific lower back pain, possibly sciatica or piriformis syndrome. The GP has not been specific. Her symptoms include stabbing and pinching in the lower back, that's the lumbar region for proper terminology, with intermittent nerve pain including pins and needles radiating down one or both legs. Now, I would like for you to choose something in this case study, a specific concern in this case study that you would like to focus on as the main part. You don't need to focus on all the conditions that are listed in this case study. Okay? So if you're talking about pain down both legs, like nerve pain down both legs and radiating pain in both legs, that's very different from one leg. And we're going to cover that in a little bit of theory right now today. And I'm going to go through some of the tests and things that you look out for and some of the care. I'll just finish reading the rest of the case study here. The symptoms include stabbing and pinching in the lower back and nerve pain, pins and needles down one or both legs. Angela has no medications but does take fish oil and Berocca, which is largely inconsequential. It's not of major concern, it's just general information. She has them daily. Her health management team, and this is important, consists of her GP netball coach, who is also the captain of the team. Angela wears high heels as part of her work and spends lots of time driving in and out of cars. So what are you generally doing in a car? Your feet are on the pedals, but what is your backside, your bottom doing, and your hips? You're sitting. That's right. You're just sitting. Yeah. And so when you're sitting, your pelvis is flexed or extended? Flexed, correct. So that hip flexion, pelvic flexion, thigh and hip flexion, is the, or FAJ flexion, femoroacetabular joint flexion, is one of the key things that can influence the muscles affecting the lower back, pelvis, and even the thighs. Okay. Angela uses heat packs on her lower back when she watches TV. She finds this feels soothing and is unsure which other healthcare providers may be able to help with her situation, has asked for your recommendation or referral to additional practitioners to assist her. That last part is particularly important. A lot of people forget this and aren't aware of our obligation. As soon as somebody asks for a referral, we are obligated to provide it, even if we don't think they need it. Okay? We are professionally and I believe legally as well obligated to provide that referral. If we did not provide a referral, even if we don't believe they need it, we are negligent. Okay? Now, I'll give you an example. There's a lady I know, and she knew other people. We actually know some other people. We have them in common. And this person's indirectly related to her happens to be a neurosurgeon. And I also know a neurosurgeon, and she's seen other practitioners and, you know, other specialists because she feels like there's something wrong with her brain. She feels like there's something wrong. And she's seen loads and loads of people for quite a few years, not just in this state, but in other states around Australia, and I believe she may have seen people overseas. And this person has said to her, no, there's nothing that we can find that's of concern, you know, and so has every other practitioner. And even though I knew all this history and I knew this person personally, she came to see me in my clinic and asked me to refer her to the neurosurgeon that I know. And even though all these other people had seen her, I was still obligated to provide that referral. And I said in my referral, very politely, she has seen and attended other professional specialists and neurosurgeons with no resolution to her concerns. If you wouldn't mind providing support or investigating as you see fit. I have indicated that she's seen other people. So that person is aware that there is a history and knows how to allocate time. So we are obligated to make that referral. The next thing in this case study is some messy sounding back pain, specifically lumbar pain. Okay? Now, lower back pain is an abbreviation. We use LBP, which can also stand for lumbar back pain. The lumbar region is the area we want to speak about, but also you can have deep gluteal pain or pelvic pain or, thigh pain, leg pain, all referred. That can all come down from a neurological or nerve impingement where it refers down from the spine into the glute, into the hamstring group region, and into the gastrocnemius. So it can refer to all those regions. Now that's the simple presentation of pain. Here we're looking at a skeleton with no muscles, just nerves and skeletal system. Okay, and if we zoom in, we can see this big fat nerve, the sciatic nerve. Okay, and if you follow that nerve's innervation, or the line of nerve, if you follow it like a little train track all the way down into the tibial nerve, okay, and you can also find it branches off from here, okay, oops, there we go, and this goes into the fibularis region where we get the fibularis longus and brevis muscles also included. So you can get pain referring down to all these areas. Now most commonly it'll be in the posterior thigh and into the gastrocnemius region where people experience the pain. Now this nerve, if we look at the anterior position, you can see it branches back up into here, okay? And there are common branches that are shared from the lumbar region that come down, but you can get impingement of the nerve in this region causing pain, okay, in the pelvic region under the glutes, and you can get it also coming back in from a disc herniation in this region here, a disc bulge. Now as the disc bulges out, and I'll show you disc bulging images later, okay, but it comes in and protrudes into this space here, the foramen. I'll zoom in here, into the foramen, and can impinge on nerves like this and this here. So this disc impinges into here. It bulges out like a balloon expanding. Okay? Now, when you are looking at people with pain on one side, any of those things is a possibility. Can you see that okay? Yeah, good. Okay. However, when it's both sides simultaneously, it's actually usually, if we get rid of this, deep in and on the spinal cord itself. Okay, or cauda equina. So it is referred to as equina, comes from the Latin meaning horse, and the horse's tail. So if we were to remove all of the skeleton, bang, okay, and you can see this bundle of nerves. It's like a horse's tail that spreads out, and I'll include an image in the video later of cauda equina. And when somebody has compression in this region, yeah, sure, they could possibly get pain in their legs. They could also get weakness. Now, weakness is a sign of a nerve conduction issue, and that's usually serious. So the muscle cannot be activated or innervated, by the person willfully. They are unable to make the muscle perform an action, and that weakness can be a sign of a nerve impingement and warrants a referral. Okay, you should refer. Now, with some nerve pain, it's a little bit different, and small areas of numbness, small areas of pain, generally not a huge concern. Small areas of intense pain preventing work, of course, it's more concerning, but small areas of numbness are of a small concern. A large area of numbness, like a big portion of a limb, like a quarter of a limb or a half of a limb, that is important. Okay? And the weakness is important. Now, if you have bilateral, meaning both sides, the weakness coming down because this is impinged, this region, the spinal cord has something pushing on it, the person will present with numbness or sensation in both legs. And the way I describe it to people, because it's called cauda equina, and you can hear equine meaning horse, equestrian, you've heard this term before, equestrian racing. No, in the Olympics, they refer to it as the equestrian or equine. So when you're riding a horse, imagine getting a saddle and putting wet paint on the saddle, then you sit on the saddle. If somebody presented with numbness when they stood up and you saw it was where the paint was from the saddle, that would be an indication that you watch out for it. Now, this is a rare condition, 1 in about 100,000 people. Okay? And it's accompanied with other things. Now, I had never, in over 30 years, encountered anyone that had even had this in their life. And then last year, the day after I taught it, a lady came in presenting with it. And my students were like, oh my God. And I said, when she left, I said, wow, welcome. We all came to the same club at the same time. Now, it's so rare. Okay, but you want to know that that's important. Both legs numb. Other things that would go with that is loss of bowel or bladder control. Okay, remember how I taught you at the very beginning. It's important to pay attention to major changes to important bodily functions. So if people cannot go to the toilet, so urinate or defecate, they cannot do that, or they just have their bowel or bladder let go and they're soiling their own pants, making a mess, then that is also important and that person should immediately be referred. But if they present even with that bilateral numbness or pain or neuropathy or weakness, you should also refer immediately. Now, in one of my student groups about 3 years ago, a lady in that class worked in a physiotherapy clinic, and she had a person come with a doctor's referral saying, please treat this person, pain, blah, blah, blah. The physiotherapist said, no, I'm not treating you. And then she called the doctor, and the doctor said, put the physio on the phone. You know, and look, I'm saying you can treat her. And he said, the physio said, no, I'm not going to treat her because I'm suspicious of this. And they said, you can treat her. I said, I'm not treating her. I'll tell you what, you give me written authority that you are clearing her for a coda equina, and I'll provide treatment. They provided conservative treatment, very, very minimal, and said, look, if anything changes, you should go to the hospital. She came back the next week, and when she was walking into the clinic, things changed. And immediately she was off to hospital and in surgery very quickly after. On that same day, had surgery within a very short period of time. So again, very, very rare. I want to illustrate that. But if you know about this and somebody talks to you about it in a clinic one day, then you might be able to help out by saying, oh, this person should go to emergency and tell them what they've got. Tell the doctors what they've got. Okay, so it's a rare thing, but it makes a very big difference in people's lives. Okay, and just being aware of it will help. So that is something in this case study which pops up as, you know, the pain down both legs, tingling and shooting down both legs, which could be, it could be pressure on the spine, or it could be, again, both of these nerves, and I'll just go back to the screen here, both of these nerves simultaneously having impingement, both of these sciatic nerves. Now, we're going to go into sciatic nerve in more detail. Lumbar spinal stenosis. So there's a little video on it here. I'll just pause. I'll skip through. So spinal stenosis, you can see here, let's make it a bit bigger. So as we look at the spine, that refers to issues that create compression of the discs, and the discs then bulge out and apply pressure. Oh, excuse me, they're talking about the ligamentum flavum there. That goes on the spinous processes. They're talking about the anatomy in general. Let's go a little further forward and see if we can get an image of a disc bulge. Here we go. They're talking about similar things to what I was discussing before. I'm looking for a herniated disc. You can get compression of the intervertebral discs, and as you get older, it affects people more. It's more likely to be there. Interestingly, as you look at an age group, you will see that the percentage of people with the problem of a disc bulge is commensurate with their age. So approximately at age 20, 20% of people. At age 50, about 50% of people. Age 80, close to 80% of people have disc bulges. They are generally not of consequence until they impact on nerve tissue. There is immediate inflammation when you first injure it in the acute stage, and in the acute stage you should not treat the area. You should wait 3 to 4 days, and of course then after that, when the inflammation subsides, then you can do more treatment. Now let's see if this shows a good disc bulge here. So there's normal compression by the looks. Oh, that's actually it compressing down and over time. Okay, erect postures, what are we going on to? Okay, here we go. So they might show a few different causes. So this is causes that don't originate from the spine. So you can see here, they're talking about the piriformis muscle. Okay, and you'll see the sciatic nerve goes through the sciatic notch, and you can get different presentations of sciatica. And I'll show you some images later of different presentations. Now, you see here, the nerve can be squeezed by hypertrophy, enlargement of that muscle, and it puts pressure on the nerve, causing pain down the leg, down the thigh and leg. Okay, you can also get the sciatic nerve going through the piriformis muscle. Okay, and it can also go over the piriformis muscle. It can go over, through, or under and be impinged. And some people have divisions of it. Some goes over, some goes through. Some goes over, under, some goes through. So there's it going through. Now this is very similar to another muscle in the body, which I will show you in the shoulder region later, and that'll be next week. And these will link together really well. Okay, so now you'll find people that use these muscles a great deal are more likely to get the hypertrophy, excessive growth of the muscle, causing the impingement. Okay, now so here's a disc and its compression. Now, excessive and repeated compression starts to damage the annular fibrosis, this outer layer here. Okay, it's a very common form of disc injury, by the way. This is the nucleus of the disc, and that can, nucleus pulposa, and it can protrude out. That's more severe. Think of it as the guts of the disc coming out, and if that were to push onto the spine, that would give you the coda equina we spoke of before. If it comes out laterally and posteriorly, so to the side, it can push onto the vertebral foramen pushing on one of the spinal root nerves. So there would be, see these pressures to the side start to stress the discs. There's anterior. And let's go here. Come on. Oh, yes. Just let it play, because I know it's close. Yeah. When you actually apply pressure and rotate, that's one of the things that really can mess your back up. Now, come on, let's go a little further along. Here we go, this might be it. Okay, so that would be protruding and affecting the spinal cord. And I'm hoping it'll show you a lateral one. Now, the nerve would come out in between the spinous process here and the articular surface. So that would be coda equina. Messy. Not fun.
My boyfriend had to do it.
There you go. Now this here, see, affecting the lateral nerve, and that would be sciatica.
Just small part can be infected.
Yes. Now the reason that you feel it down your leg is, I'd like you to think of it like a light bulb. Okay, so if I go and I get, I'll just do a screenshot here. Okay, so let's think of it like a light bulb. I'll just do this one here, bang. Here is a human brain form. Okay, hit the form. Then you've got a spinal cord coming all the way down. I'm doing 2 lines for a reason. And then it eventually goes out to someone's foot. Okay, and here's a toe. Boom. A toe. Okay, there's a toe, and you've got these 2 little, think of a nerve as being like 2 wires. Okay, now when someone touches your toe, it's like a little switch making the 2 wires touch here, and then there's a little light bulb in your brain. Boom, there's a little light bulb that lights up and says, my toe's been touched. Does that make sense? I touch here, your brain says toe's been touched. Now, because the pressure here, this mechanical pressure, stimulates a nerve response that sends an electrical signal up, that's the basics of how it works. But what happens if we decide to make the wires touch here? It still gives you that sensation. You still believe your toe has been touched. You could touch it here. You could make it, give a short circuit here. You'd still feel like your toe had been touched. So that's why when somebody gets, in their pelvis, boom, there's a pelvis, great pelvis, hey. When somebody gets a bit of pressure on some nerves, in around their glutes in their pelvis, they can get pain going all the way down their leg and into their foot or their heel, depending on where that nerve has pressure. And then it'll send signals up to the brain, and whichever little circuits have been short-cut or short-circuited, they will all light up. And that's why you can feel like the pain goes all the way down your leg, because you have receptors to say you've been touched at different heights. Does that make sense? And they all join back up in one area, up here or in here. They're all grouping together. So you've got, I use this black one here, for a muscle in the thigh, you've got a sensor here and two wires that come back up here, and then you've got another one over here for lower down on your thigh, and those little nerves or wires come back up here. They all start to group together, and when it gets squeezed, everything short circuits. But you might only have compression on one part of the nerve, one side, one edge, or it could be the whole nerve. So depending on how much is compressed is how many different areas you'll feel sensation usually. Okay, and it often goes down the back of the thigh. It can be quite fine, it can be quite broad, and it can go all the way down to the foot. So that is sciatica, and coda equina, of course, is pushing on the spinal cord, which is where both sciatic nerves eventually join in. Does that make sense? So if I get pressure on the spinal cord, right in here, I'll show you the difference. Here's the spinal cord, nice and wide. And then it splits off, boom, boom, to each thigh and leg. If we put pressure here, where these two come back up in, you'll feel the pain down both sides. Okay, do you see how we can pick the difference and why it's important? It may not be this. You could have pressure here and here, because they might have a problem, especially if it's come at the same time. They say, oh, it happened at the same time, both legs, like seconds apart or an hour apart. That would be worrying. If it happened months apart, it's less likely. It would be, you know, months apart could be one glute and then one in the spine. And you could have pressure as the nerves, and if I draw just quickly vertebrae, there's a vertebrae, boom, and another one, boom, and you'll get the nerve. So there's the spinal cord inside. That's the spinal cord. And branches come off out to the side, like that. So you can get pressure here, and it would go down to that leg, you know, or pressure here, and it would go down to the other leg, okay? Because this is called a spinal root nerve, and that is the spinal cord, okay? Incidentally, I just want to remind you of something with spinal root nerves or spinal nerves and cranial nerves. They have a slightly different naming system. Slightly different naming system. A lot of people get confused when they see something like C8. Have you ever seen C8 written somewhere? How many cervical vertebrae do we have in our neck? 7. But sometimes you'll see C8. Well, the first cranial nerve is actually, you know, you've got them up inside your head and so forth, and as they come out down through here, you've got, you know, you've got CN for cranial nerve, and then you've got your cervical spinal nerves. But the very first one comes out on top of the vertebrae. So this would be the nerve 1, and then the second one is nerve 2, yeah, and the third one is nerve 3. So what happens is, by the time you get to vertebrae 7, you've got another one under vertebrae 7, yeah, and another one, and the first one is above vertebrae 1. So you'll actually see the abbreviation C8 referring to the spinal nerve for the cervical region. So there's more nerves than there are vertebrae. Okay, so if you see that, it's not a mistake, not a bizarre form of nomenclature. It's just referring to the spinal nerves. Now, other things to discuss from that particular problem that we have in our case study include, let's see, Lucy has, sorry, not Lucy, it is Angela. Okay, Angela, real estate agent. Yes, okay. So something that provides relief is the heat packs. So muscles contract when you're cold. When you're cold, what does your body do with your muscles? You shiver, yeah, you shake and shiver. That's muscle contraction to warm you up. And when someone overheats, do they start shivering? Do they run around, or do they just want to flop? Yeah, if someone overheats in a car, you know, like they carry the person when they overheat and they're all floppy, your muscles relax when they get warmed up. So there's some relaxation of the muscles in warming them. So that could indicate something that is helpful. Keep that in mind in your case study. There is some things that we're going to discuss now, and I'll try and include additional videos for these. We're going to talk about a bunch of different tests, so I hope I remember them all off the top of my head. So these are for some of these concerns. So you have something like the FAIR test, which is FAIR, flexion, abduction, internal rotation. You'll have as well a quadrant test for the spine, where you lean around, you do spinal flexion and extension, and that is a provocative test, and it can also provide alleviation, and it helps you differentiate between different problems. Okay, whether it is more likely to be a nerve root compression from a disc concern, or if it is more likely to be pain from something like a facet joint. And then we will also cover the Thomas test. I think we've done that with you before, the Thomas test. and we're going to cover off the treatment for some of these concerns and also looking at pelvic tilt with postural assessment and so forth. Now, the way people present when they have this type of injury, how they'll walk into your clinic, is they may have trouble moving their legs because of pain. They'll often have stooped posture, and the antalgic gait, meaning the way they avoid pain when they walk, antalgic adaptation, the movements they make, are often leaning away from the pain. And sometimes that can actually make the symptoms and concern worse. Okay, I'm going to just try and do something here that may work well. I'm just pausing this